All right, thanks everybody for joining today, our final CoCM SIG meeting of the year. I wanted to start by saying a big thank you to Tisha. This will be her final meeting as our co-chair. She has done an amazing job growing this group into one of the most well-engaged, well-attended CoCM SIG groups that we have as part of CFHA. So a big thank you to your leadership, Tisha. It's been wonderful to work with you on this initiative, and we're looking forward to more opportunities to collaborate in the future.
Yes. Thank you, Laura. It was a great privilege for me. It was me and Diane Powers and Lori Rainey who kind of started the work group or restarted. I think there was one before, and I think I know at least Patty Gibson was a part of that initial start, and I really volunteered because I wanted to learn, and I was just really uh, just starstruck to be working with Diane and Lori. And so I've learned a lot and I really appreciate it. Obviously, we'll be part of the group, but excited to see what's going to be happening in the future.
We're so thankful for you. Monica Harrison is going to be stepping up from secretary role to co-chair. We just had the applications closed for the secretary, so we'll be announcing more information about that as that comes. Just finished up at the end of last month with closing for applications. Our next session would have been on January 1st, with that being on New Year's. We're going to likely end up moving to February as our first meeting of the year. So be on the lookout on the Basecamp for more information related to that. So our topic today is a really exciting one. This was an area of active interest on our Basecamp messaging. So we're going to be talking today about how to go about navigating, identifying behavioral health care manager hiring ratios. This is an area that we have some awesome community members who I'll introduce shortly, who you're going to be hearing about from practical experience, lessons learned, the good and the bad, about kind of navigating this. If you want to read more just about kind of the context to what led to this SIG today, I encourage you to go back to the October 4th posting from Shonda Wells. There was some really rich information in there about the considerations for this, looking at both data-driven as well as practical-driven approaches. There, are also some tools on there that were shared by Cody, and great insights also from Verna as well as Cody on sort of these soft skills as well as hard skills to kind of be thinking about. So those will be things, if we're wanting to kind of hear more about, I encourage going back to that chain to discuss more. All right, so first we have Janine Fonfera. She is the manager for integrated medicine at Middlesex Healthcare in Middletown, Connecticut. And she led, prior to that role, the initial integration for Hartford Healthcare, which is a large health system in Connecticut with multiple outpatient primary care practices, as well as a home health department and a large behavioral health department. And now she's leading the way in Middletown healthcare system, implementing integrated care there. So we're going to hear some great insights from her. We also have Ashley Shattuck, who has taken over the lead for Janine. She's leading the integration efforts now at Hartford Healthcare Medical Group. So really looking forward to hearing these sort of cross pieces of how that's looked for one another. We've got an exciting opportunity to hear about that. And I've had the chance to meet several times with Ashley and her initiatives, kind of evolving CoCM as well as PCBH to work together. And she previously worked with Monica Harrison, both as a PCBH clinician and BHCM. So she'll have some great insights to share. And we also have Chris Weatherington, or Wethington, did I say that correctly, Chris? All right, Director of Practice Support from NCHC. And that's a large program in North Carolina. The organization, to my understanding, has changed a lot with programs, but one of which that's really been stable has been supporting medical practices who are integrating. And it'll be helpful to hear about what this is looking like on the North Carolina side with funding streams and kind of like looking at those dynamics. There's also a lot of engagement from my understanding from Monica about the American Psychiatric Association in North Carolina. So this will be really great to hear these different diverse as well as intersecting perspectives. So my first question I wanted to raise for you, Janine, can you share a little bit about how your team has approached discussion and decision making surrounding behavioral health care manager ratios for CoCM services?
Sure. The first thing I tell you is forgive me if my voice is a little bit off. I'm just recovering from a cold. So I'll first say that the decision making comes, I think every organization is different and you have to do what's right for your organization, but we've done lots of research through the years about staffing ratios, starting with full-on integration where we have clinicians in the practices, and then that morphed into more of a blended model with PCBH and collaborative care management, CoCM. And that was at Hartford. And then here at Middlesex, very similar, started the programming here the same way. And we have a lot of reasons why we choose those models here. However, the staffing ratio, so everything and anything we do is research and evidence-based. So any choices we've made are always supported by others who've gone before us. And the 80 patients per clinician or per case manager, I should say. I want to make sure I use the right language. So the 80 patients per case manager with adherence to the intentionality of the CoCM codes is our true north. So 80 patients on the registry at any given time per clinician and per psychiatric consultant. They're on for a 6-month period of time. Patients are on for a 6-month period of time. So some will naturally fall off as we accept others in. And I've heard a lot of discussion about what the 80-to-1 ratio looks like in different organizations. So I'd be happy after others speak to kind of delve more into what that looks like.
Chris, let's hear from you on the same question. How has your team approached this discussion and decision making surrounding behavioral healthcare manager ratios for CoCM?
Sure. First off, I want to just let you know that this is the first webinar I've ever done where I'm sitting behind a grand piano in a hotel. So I'm going to try to do this without getting interruptions from people asking me to play the piano. But typically, it can vary. As Janine mentioned, it really varies practice to practice. But typically, the range, what we've seen with the 43 practices that we've got up and running in North Carolina, independent practices and federally qualified health centers, is usually 60 to 80 for a full-time FTE. Now, some people say, well, gosh, I should really be at 75 or 80. It's really going to come down, one, to the comfort level and the experience of the behavioral healthcare manager that you have. Are they licensed or not licensed? What do you have them doing? Typically mild to moderate depression, anxiety, and pediatric ADHD. If you say to those things, typically that's a little easier, but when you start adding some things to the plate, they get a little bit more complicated. And if you're working with a small number of primary care providers in this model, it makes it easier to ramp up and understand the workflows. When you've got multiple providers or a very large office, that can get a little bit overwhelming to a BHCM because they all have their different personalities, their preferences, their understanding of the model. So, but typically the range for a 1.0 FTE is 60 to 80. And again, there are these variables that may influence that number. But what we always tell people is you're not going to beat that number overnight. You've got to crawl, walk, and then run. No point trying to sprint right out of the gate doing this. It's going to take you several months to get up to break-even status. It can take you 3 months. It may take you 6 months. It just depends on how quickly you go. And Janine, to your point, is your registry working for you? Have you got it set up the way you want it? Do you have your workflows down? Are you optimizing the information out of the EHR? Have you identified your patients and you've got it down to a laser beam who those people are? And so over time, you probably will get to 80 at some point, but it may never be 80. It might be 65, 70, 75, and that's okay. You have to figure out what is the sweet spot for your behavioral health care manager, your PCP, and your psychiatric consultant. At the end of the day, if you don't have the PHCP or the BHCM feeling comfortable, the model won't work, and you're going to lose them, and then you're going to have to start all over again. So that's what I would suggest. It's just based on our experiences. Again, across 43 practices, you've seen one practice, you've seen one practice, but typically that's the range.
Awesome. And Ashley, same question. So can you share for us a little bit about, what you've experienced in terms of approaching discussion and decision-making surrounding behavioral health care manager ratios for your CoCM services?
Sure. So I will say I was lucky enough to inherit both integrated care programs at Hartford Healthcare, and I'm really happy to see Janine's face on here. So for CoCM, we've landed on our target caseload of 75. Originally, it was 72 when I inherited. We have Epic. So we do a lot of looking at, outcomes, screening scores. Are we getting more mild to moderate? Are we getting more moderate to severe, right? And thinking about those AIMS caseload number guidelines and really trying to find the sweet spot. So 75 seems to be working. So the way that our system is set up, we have 72 primary care offices spread everywhere throughout the state, right? And our current model is in 6. And so that is 40 PCPs. And so that has resulted in a 75 approximately caseload, right? Waxes and wanes, changes over time. We're constantly evaluating with a psychiatrist, et cetera, et cetera, et cetera. What's interesting though, is we are expanding in a different way. We're still going to target we're moving from what's called like farming patients, like PCPs, letting them refer. And since I inherited both programs, and this hopefully is helpful to know, I didn't necessarily have as much bandwidth to really gain provider buy-in for CoCM as I did with PCBH. And so what's really exciting now is we have this executive leadership support to really expand CoCM and target patients who we think would be ideal based on the data that we've collected in Epic over the years. So it's really exciting. And we're expanding to, I believe now it's 50 something primary care providers, right? But they're only able to refer patients where we've identified versus them self-identifying patients. So it's something new and exciting we're trying. We're still going to look at the 75 as the target. But we'll certainly, everything comes with reevaluating, right? Plan, do, study, adjust. It's part of what we do in integrated care. So I hope that's helpful.
That's fantastic. So some of the things that came up in that thread was about this idea of benchmarking with data. And so what I'm hearing at each of these different teams, you're using that BHCM caseload as the key sort of data-driven for hiring, kind of looking to try to target that range or that specific one. Other tools, this was shared in the chat. You can use some benchmarking tools that are found on that thread that Cody shared if you're trying to look at sort of the population size and look at depression, anxiety rates. But when we're looking at in terms of BHCM utilization, it sounds like what I'm hearing from all three, Janine, Chris, and Ashley, is it's really helpful to look at those caseload sizes and kind of identify targets based upon various factors. Chris, can you tell me a little bit more about what successes you've seen with that, ratio decision making? You've got a lot of experience across North Carolina with that. Can you share a little bit more about those successes that you've found?
Okay. Well, first off, I just want to say we would not have been able to do it without Diane Powers and Monica Harrison. So they've been walking through with us for the past couple of years. But I would say in addition to those things, what we have is practice support coaches that are trained in the collaborative care model. Many of them have a behavioral health background, some do not, but they all have a primary care background. And what we've worked with practices on to help them get up and running in the model is getting the workflows down, making sure that the PCP, the behavioral health care manager, the psychiatric consultant, and the appropriate office staff are all trained up on the model. So in North Carolina AHEC, we offer about 20 courses in it, but we always insist that they take the first 3 to really make sure they understand the model. They're about 45 minutes a piece, but that's key. Also, the data registry. Practices don't have to use a data registry that we've developed in partnership with Community Care of North Carolina. They can use spreadsheets or their EHR. We're kind of biased towards the registry that we've created. We've made it free for the first several years, and so that's been a plus or a satisfier. Behavioral health care managers, sometimes practices have all kinds of ideas of who's appropriate for that role, and certainly there are a lot of folks that are appropriate. We're sort of biased towards licensed folks. But we making sure that the person in that role is appropriate for the patients that they're going to see, and also making sure they understand the billing and the coding. If practices do not feel like they are bringing in the revenue to cover their costs, they quickly exit the program. And so it's really key to make sure that their insurance contracts fully cover those codes. And even though insurances say they do, it all still comes down to what your contract says. Make sure you've got those codes included along with the reimbursement rates to cover your costs. In North Carolina, Medicaid in North Carolina has set up the reimbursement for 120% of Medicare rates, which is fantastic. So we're able to go all payer in on this. So that's key to helping that behavioral health care manager. But also, we've created sort of learning collaboratives for behavioral health care managers so they can all get on calls with each other and learn from each other, and both what to do, what not to do. And then I guess finally is just making sure that the behavioral health care manager feels empowered to call people out, to make decisions, to feel like they have ownership versus a top-down approach from the PCP. And the psychiatric consultant, because sometimes they aren't all on the same page, and just empowering them to bring them together, make decisions together, but understand that BHCM is the bedrock, even though it's built out under the PCP, it's under the PCP's license, is the BHCM. So there are a number of ways to do this, and we're not perfect. We've made some mistakes along the way, but that's what we have found seems to work, and that's where we are. So.
It's really great to hear about sort of that continuous process improvement. This is something that we see a lot with the different themes. And, that call out for getting that national training with AIM Center first, and then creating this localism approach of having sort of these in-state trainings that you're putting together that allow for, making that more personalized for the needs. Can you share more about what's in those training programs?
The one other thing we do offer in our state, which we've been very blessed to have, is the North Carolina Psychiatric Association has around 25 psychiatrists that have all signed up, willing to contract with practices. We've got an organization called NCPAL, which is a collaboration between Duke University and UNC Chapel Hill, which they don't get along in basketball, but they get along well in the psychiatry realm, providing pediatric consulting, and actually at no charge. And it's subsidized by the North Carolina Department of Health and Human Services. So making things easy has been helpful. And of course, there are some practices that have gone with turnkey models, and that's okay too, because we don't take a one-size-all approach with everyone. And so for some that they prefer to go to the turnkey route with the BHCM and a psychiatric consultant, and that's great. And we partner with a number of organizations that provide that service. So it's a holistic approach with a continuum of solutions that meet the practices where they are. So that's what we're doing in North Carolina.
I love that. So you've got this really clear framework, this stable infrastructure with multiple levels, state supports, medical association supports, but with this flexible application approach, which is so cool. One final follow-up question for you related to just the trainings. What kinds of things do you include in those trainings And how do you feel that impacts the BHCM hiring and retention?
Well, you can leverage the Ames courses, obviously, but we've got 20 courses that we have put together, and some of those are actually presented by Ames, and others are by other experts around the state of North Carolina. But a lot of our sessions cover topics at the macro level, and then we get down to the micro level. And it goes various things, workflows, different types of patient populations, skill building sessions. In fact, we did something with Ames over the past couple of days in Fayetteville, North Carolina, a skill building workshop for BHCMs over the past couple of days, which we got pretty good attendance on. We have an annual summit. We did one last year. We're doing a second one this year just for BHCMs. We have roughly about 100 that come out, and they learn from each other and they learn from experts that present. So we have that, and then finally we have a monthly learning collaborative where we get them all together. And again, you're talking high level courses, very academic, topics, but then we also have a number of courses that are very specific to how to get the work done. So how to diagnose patients, how to screen effectively, how to handle different special patient populations. So, I mean, it's a work in progress, but that's where we've gone. But one final thing I'll share with you, as of last month, the state of North Carolina appropriated $5 million to give to primary care practices to get the process up and running. So each practice location is eligible for up to $50,000 to get the program up and running. So we could not do this without the North Carolina Department of Health and Human Services and North Carolina Medicaid to provide all these resources. So that's really where we are. And then the coaching support is very much one-to-one. We actually go into the office, sit down with them, and work on the workflows with them until they feel like they got it down. And that's been very helpful. And that's provided at no charge as well.
What a wealth of offerings. That's really cool. And a lot of opportunities for all of us to learn, and sort of things that we can bring back to our states to advocate on or model. Janine, let's hear from you. You've had different organizational experiences. Can you share, kind of in your travels with integrated care, what resources have you found to be most helpful for those behavioral health care manager ratios? You had mentioned that there was evidence-based and evidence-informed resources that you've seen.
Sure. And I also want to acknowledge Ashley. Ashley came into Hartford Healthcare with such enthusiasm. She had been working in Massachusetts, and Massachusetts healthcare system was a little more forward thinking than where we were in Connecticut at the time. I'd say when we first started our work, we go back at least 15 years, maybe closer to 20, maybe now. It's hard to remember. And so, of course, back then we only had PCBH. And so we were able to implement, so remembering that SAMHSA level 6 integration is considered the gold standard for healthcare integration. And so that, again, going back to True North, that was always where we wanted to be able to settle. And then we met Monica. Monica had been giving a presentation here in Connecticut through NASW, and I met Monica for the first time through a colleague. And then about a year later, I called Monica and I asked her to come work for us, because at that point we had a grant. Another grant was given our way through Healthcare Innovation, and it was about starting CoCM. And so again, we had already had a pretty robust world with PCBH, and we piloted different ways of doing the work that made the most sense for our organization. And so that could be in part why we have somewhat held on to this model the way we have in Connecticut, though we feel pretty strongly that what we're doing for Connecticut in any case is the right thing. When we started our work, we researched at Montefiore in the Bronx in Manhattan. We researched at Brigham and Women's in Boston. And we partnered with Maine Behavioral Health out of the state of Maine. So we always knew that our partnerships were strong, and we kind of took the best of the best. You know, in New York or in Boston, they have these huge grants that can support the work. But in Connecticut, you know, we're very fortunate the few grants that we did get. So we always had to make it work where at the end of the day, we weren't losing our shirts. And the way to do that here, and the way we're currently doing it now is, I'll just kind of explain to you a quick day in the life, because that'll explain to you how we get to our staffing. So we really move with the model that we are committed to addressing the quintuple aim, that we really have a commitment to our providers here at the healthcare system, our primary care providers or our specialty providers in the healthcare system. And we can, sorry, because my mind will start going in all these different directions, which is, well, you know, we are able to put a CoCM. We are able to do a little bit of CoCM right now with our in our perinatal program. So we've started to lay the groundwork there. We've started with some of our other specialty practices, because it doesn't only have to come from a primary care provider. It just needs to be the primary provider for the patient. So your referrals can come from a plethora of resources. That said, so if we go with the premise that our clinicians are in the practices to have a schedule of patients throughout their day, but very importantly, to be interrupted during sessions, to move at the pace of the primary care practice. It's not traditional psychotherapy. And we're really committed to brief treatment modalities, and which for us has been the hardest lift with clinicians. Most of clinicians are, you know, seasoned, and we've been working in the field for a long time, and most of us worked in the field doing a 45-minute hour. And so to help clinicians start doing a 30-minute session, which feels meaningful to them, you know, is one of the lifts. So we have our clinicians in the practices, they are seeing patients, and when they have downtime, when they have a cancellation or a no-show, is when they fit in their collaborative care management work. So collaborative care management is a complement to what we consider our bread and butter work, which is in the practices, seeing patients, still meeting with patients face to face or through telehealth, but it's all still within our own health system. At least the work that I do, I should say, the work that I do here in this health system is that model. So really we have our staff that is assigned. So if you say, so we have one clinician per 5,000 patients. One clinician in a primary care practice per 5,000 patients. And of that 5,000 patients, we're going to pull 80 to have their medications reviewed, managed, consulted upon, then the recommendation going back to the primary care provider. Oh, and the other thing I should add is that we are in a residency program here. And that it was purposeful, because our goal, and certainly working with Ashley and Monica throughout my career, we all kind of are cut from that same cloth of worked in the mental health field for our entire careers. We've seen firsthand the lack of resources that have been given, right, to mental health care and treatment throughout our entire careers. And we know that the separation of mind and body is what got us here. And so we work really hard to be the face of integration, that we want mental health care and treatment to be normal, like every other, I'll answer that question in a moment. So what we talk about is a primary care provider at one time probably would have never touched diabetes. Now you have a primary care provider, they treat mild to moderate endocrine issues all day long. They treat mild to moderate cardiac issues all day long. Yes, some patients have to go to an endocrinologist. Some patients have to go to a cardiologist. But 70% of the patients that are already walking into your primary care practices, research shows, have an underlying mental health condition that very likely has not been addressed. So you put us on the front line and we can address mental health conditions earlier and earlier, so that our goal is to not have this backlog of patients that are trying to find a social worker, a PsyD, or a psychiatrist out in the community on their own, right? It doesn't work. We have a huge clinic here that we see, it's a lifespan clinic, so we can see patients from birth to grave. And of course, we, like probably every one of you, the waiting list is a mile long. Our clinicians are, back to back all day long. There's turnover. And what we find is clinicians who work in this model, integrated care models, love the model. They want to work in this model, they enjoy the model. So a PCBH model, to answer the chat question, the PCBH model, primary care behavioral health model, Hunter and the Hunter, our book, right? Ashley will remember this, it's been what we used to, we called it our Bible, and everyone knows, most people on this call know Chris Hunter. And so this model started out of the VA, 30 years ago. And then, so we took that model. That's 1 per 5,000, per book, yeah. And we just kept with that model. And then from there, we've built our CoCM work. Now, I will tell you real quickly, we've let someone go. Recently, I let a clinician go who she just wasn't able to manage the work. And so now I'm sitting with her patients because I'm filling in until I hire someone new. And it's been great, by the way, I will tell you, to be back in with patients. And one of the several patients have already told me in the past 2 weeks that the way that clinician introduced collaborative care management to the patients, they weren't interested in it. So I will say this to everybody here, you have to make sure that when you're introducing CoCM, you're really helping your folks understand, your patients understand that we are an extension of their primary care provider, and we work as a care team, and a consultant, I will be on that care team meeting when the consultant is talking about your case. So, because that is, it's about trust. It's about building trust with your patient population. And from a safety perspective and from a legal perspective, we are always making sure that we are doing the best that we can possibly do with the resources that we have. So we have case managers in this organization as well. And the case managers are able to then partner with us at the family medicine practices. I hope that answers your question. I'm not 100% sure I answered your question, but
I think you sure did. So just to kind of highlight for the group some of the resources that you described that have been really helpful. You gave so many excellent examples. I'm going to put them into some categories. One is leveraging those foundational principles. So you talked about the SAM cell levels of integration, and you described in your opening this true north piece. So having some of these foundational principles can be really helpful. You're leveraging data resources. So really using how many clinicians per patient, and then using data to pull those 80 patients who then have to have the medication managed. So leveraging that part of your resources. You're leveraging the lived experiences for you as well as patients and team members, right? Practicing between integrated care and specialty care. You've got that lived experience, and that is a resource that's really helpful for training, hiring, as well as maintaining a care team. The other one is those social resources, looking to the big medical centers. What are they doing? So seeing kind of those lived experiences and leveraging then how you experience that as well with your expertise, and those relational resources, that piece of how we explain the program, how we describe what we're doing, those are all so important. So I think there's just a wealth of all these pearls that you've described. From the hiring and onboarding perspective, Janine, how is that dual role of kind of the BHC and the BHCM? How has that kind of impacted the way that you go about determining ratios, hiring? What are some considerations that would be helpful to point out for others that are trying to do one role or, one person, two roles?
great question. So I want to say it was through Intermountain, but I can actually get you that resource. But there are actually interview questions that are designed for when you're hiring people into this particular role, because of the nature of somebody just said it, that, you know, we are definitely working to target. We are treating to target, and we are definitely talking about behavioral activation and skill building and psychoeducation, right? And so we're interviewing people. That's a lot of what our interviews are about.
A darker green.
Oh, okay. And also, you know, we've had people who've said, oh, no, that's too much of a ratio. That's not something I'm interested in. No problem. Like, we'd rather know that up front. And it sounds like a really big number until you're in it. And then when you're in the work and you're doing the work, it's very manageable. It's extremely manageable. We certainly don't, you know, we don't, I mean, our documentation is long, not for CoCM. That's the other thing I will say. Our documentation for CoCM requirements is far less than what we have to do for our PCBH work. So that also helps people when you're able to show them this is what the requirement is. And then having the partnership from billing, because our clinicians are not responsible for any of that when it comes to the CoCM work. We do our own PCBH billing, but the CoCM billing is done through the organization, and it doesn't fall on our clinicians, which is also really important and really nice. But yeah, I think that for this work, you really need to make sure that you're hiring people who are interested in changing the way healthcare is provided, right? It is about blowing up the way we've done it for all these years. And, you know, Ashley knows I got my doctorate in behavioral health integration through Cummings Graduate Institute. And so Nicholas Cummings, who is the founder of the PsyD degree as well as the DBH degree, you know, he worked for both, right? He worked for the APA and he worked for insurance companies. So the models understand both worlds. That we have to be good partners with our payer sources as well. And at all times, we're all working toward helping someone get better. And so that's a big part of our work. Yes. Yes.
Yes, those commonalities that ring true, and performance-based interviews, like really like looking for that fit is so important. Excellent pearls. All right, last but not least, Ashley, you know, you've definitely got a large number of clinics, providers that you're needing to support. And I know it can be really hard to scale CoCM and other integrated care services to that. Can you talk about some of the challenges that you're experiencing, as well as how you've been kind of tackling overcoming those challenges in the CoCM expansion?
Yeah, great question. I would say first and foremost, and Laura, you, Jen, and I met about this, is provider buy-in. Because I think we all know that a CoCM program isn't going to be successful if your primary care providers aren't bought in to the idea of a team-based approach to addressing mental health concerns and improving someone's overall health, right? And moving from, you know, a referral-based kind of lens to more of a standard of care lens. And so I would say, you know, it's been CFHA has really been invaluable to me, I've been in the manager role for 2 years now. It's been invaluable to me to learn tips and tricks, and certainly under Janine and Monica's prior guidance of what's going to work for our health system and what's not going to work. Because our PCPs are motivated by different things, right? Some are motivated by compensation, some are motivated by like their actual patient outcomes and being invested in a team-based approach. You know, it was interesting how this expansion came about. I really saw an opportunity. So within Hartford Healthcare, you know, we have our medical group, which is made up of primary care and specialty care. But one of our other entities is a very large, robust behavioral health network. And our consulting psychiatrists historically have worked for that. So I saw an opportunity for our consulting psychiatrist who was looking for more hours and advocated for how wonderful it would be if we were able to expand CoCM, which historically, you know, can be more scalable, especially in a health system like ours, where, you know, our 13 LCSWs are covering 41 primary care offices, the BHCs. And some offices are small, some offices are big. We don't have these large health system or large health centers per se, when it comes to primary care. So that being said, I was able to advocate for actually our psychiatrists to be employed by the medical group, have more hours, and strategically design a way. So this is what's nice about inheriting a program, right? You get to learn the basics of how it's been going. And then if you see an opportunity, you seize it and start to advocate your butt off. And luckily, we're at this place in Hartford Healthcare where it's being, there's more of a spotlight on behavioral health integration. And so we do have an opportunity to do something different. But I would say, you know, yeah, that sounds great, right? Let's hire a psychiatrist and let's have more hours and let's see more patients. But then there's the operational piece of, well, how are you going to pay for that, right? How are you going to get these, you know, the BHCM's panels full in a time, you know, in a timely manner to make it viable, right? And so then you sort of have to balance, oh, well, this is great for health outcomes, but like, wait, we have bills to pay. So I think that's always been a challenge in our organization. And I'm probably not saying anything new to anybody here on this call when it comes to navigating and balancing that. I feel lucky that our executive leadership has really championed expansion. So I couldn't have done it without kind of being in this moment and seizing an opportunity that just sort of came our way.
So there was a a comment in the chat that I think could be posed as a question. Says Kimberly says it seems that a lot of organizations do not allow time for fostering relationships between psychiatrists and PCPs, and that trust is really critical. So I wonder if any of you or all of you would like to share with us kind of how you've worked to foster those relationships between the psychiatrists and the primary care providers. I'd love this too because we just hired a new psychiatrist and rolling out into 3 to 4 new clinics the next 3 months. So I'd love to hear about your experiences with that.
I can just quickly continue the expansion conversation and add our strategy for expanding was provider education, right? PCP education. And we actually, the psychiatrist and I designed a slide deck and met with all the PCPs. We did 4 education sessions and actually carved out that time. We were able to get them for 45 minutes, which of course I could talk about it for 2 hours. But that was a big win during their lunch hour as like a lunch and learn type thing. Because a lot of PCPs are motivated by learning and growing, not all, that's okay. But we had a really great turnout when we actually dedicated time and gave them some robust education with the psychiatrist. So that worked really well.
You gave a lot of great examples, Ashley, of leveraging what you had and what you could find and capitalizing on that to then overcome challenges experienced. And, you know, that point of having lots of clinics, but very small, that's going to be a different approach for hiring, for training, for onboarding, for sustaining, compared to a large healthcare center. So great example of kind of how you took what you had and you took the advantages of that to optimize, and then also looked at sort of the ways to use the resources you have to overcome challenges.
And I will say one thing about onboarding. This year, we started having both the BHCs when they start and the BHCMs shadow a primary care provider for a day to help leverage those separate realities. And that's been really successful.
Awesome. Where are you kind of at with the hiring scheme and kind of that piece with your behavioral health care managers? How have you been conceptualizing that with all these moving parts?
Well, we actually just had a PCP or a BHC convert to a BHCM. So that worked out well in terms of job posting, etc. But really we were able to advocate for an additional FTE, right, full-time employee, when we reached or kind of crossed that threshold of 75 patients, that target I mentioned, right? And so that is when we were able to show like, hey, now we need someone else. Let's go about aggressively recruiting. And we were lucky enough to have one of the BHCs flip.
Yes, that's a great approach. So kind of as we're thinking about this, looking at percent capacity or full capacity of registry caseloads can be a good turning point. That was something that was put in that Basecamp cat as well, kind of looking at fully scaled up and looking at either, having in the pipeline somebody to hire or thinking about waiting to do that hiring. This great idea of converting between one role to another, we can leverage people within our care system. Some people may be better suited for the care manager role versus BHC if we're keeping them separate. Wonderful insights. With 10 minutes left, I want to open it up to open discussion. Any questions for our speakers today? Other insights people want to share that have resonated from our conversation?
As we're waiting for someone to ask a question, I just also wanted to add, because I was remiss in not adding this. Lori, we hired Lori Rainey. We hired Health Management Associates back, God, I don't know, 10 years, 8 years ago, maybe. And they came in and they did a full-on training for our entire, for clinicians, for the billing department, for Epic, right? For everybody, they did. So Lori Rainey was also involved in that. So I just thought it was important to mention that.
Excellent call out. So as another resource, we can use technical consultation services. I know in New York State, we've got some technical consultation paid for by the state. CFHA has technical consultation, technical assistant programming. Martha Sauceda leads that up. We've got the Brain Trust here. We've got other, contracted options like what Lori Rainey does with different organizations. There's so many different opportunities. The AIM Center, I know, offers tons of awesome technical consultation supports. So leveraging that brain trust and reaching out to others who've had trials and tribulations is really helpful.
One comment also, as the PCPs are also usually bought into this too, because not only do they want to get out of a situation of being in a 10 by 10 room all day and half their patient panel be behavioral health related. That's not what they feel they were trained to do. But the value-based world for primary care practices put in a lot of emphasis on transitions of care, keeping patients out of the emergency room in the hospital, managing the diabetics, screening and managing diabetes, screening and managing hypertension. And you can only move the needle so far with those patient populations, just addressing the physical health needs. So the PCP should be bought into this type of model because they know they're going to actually move the needle on those other patients. And when they move the needle, they not only have greater provider satisfaction, but you have greater patient satisfaction. And financially, not only the collaborative care revenue that comes in directly, but when they close those care gaps, they are getting quality incentives from the payers. And that's the indirect revenue. And then finally, they're freeing up appointment slots for those new patients or other types of patients they want to bring in, which expanding access to care is a good thing. And they're also typically rewarded by the payers for doing so. So I think the BHCM really needs to make sure that they know their role, but also know their value in this because if they do this really well, everybody wins in the practice. The patients win, the total cost of care is brought down. So I think sometimes the practice managers and the PCPs can lose sight of that a little bit, and they just need to be reminded. And that would help the BHCM with retention.
Chris, you're really getting at the secret sauce when it comes to that elevator speech, right? So it's geared towards who your audience is. And sometimes the BHCM may know that, but a lot of times if they're not working in that world of medical, they're not. And like Ashley had shared, PCPs are motivated by various things, and so the value-based payment example you gave here hit on multiple, where It's the right thing for the patient. It also helps with reimbursement and payment and incentives. And it actually moves the needle. It actually is successful. So excellent example, I think, of that, those soft signs, in addition to kind of the hard data that can help with this approach. Kim, I see you got your hand up. What would you like to share?
I was just curious. I have a question for Janine. Janine, I know you talked about you have a PCBH model and that the BHC is providing services to your patients, and when they have downtime or extra time, they're providing the BHCM role and seeking out or managing those 80 patients. Is it ever challenging for them to not have enough resources or to struggle with meeting the needs of acting in that BHCM role and meeting that patient population? I'm just curious about the balance, because a lot of times we hear, oh, we got to keep them separate. So this is really interesting to me.
Sure. Well, I would say that at first, I would say the clinicians who are currently doing this, they were very overwhelmed at first. They were very concerned about having enough time. Where am I going to fit any of this work in? And then they have started to structure some of their phone calls and their collateral work during those times when they do have. It started with they had scheduled downtime at the beginning. So when we first introduced it, we opened up some slots so that they would have a little more time to get used to it and to socialize the model, appropriately with the patients, most importantly. And then now it's kind of become, now we're just ramping up our CoCM. So who knows what it'll look like 6 months from now. And by then, hopefully, our case managers who already work for the organization, but who are pretty backed up because they have their own caseloads for severe and persistent mental health conditions. So we're tapping into another part of the organization that already has that resource. But again, I'm going to say what we continuously go back to is, this is about a mission. It's about a vision. It's about holding on to that greater good. So I really feel like people who are doing this work understand it, or people who are doing this work who love the work understand that we're really trying to kind of right a wrong. We're trying to correct something that really mental health care and treatment should have been on par with the rest of medical care and treatment, and should be on par with the rest of medical care and treatment. It's one body, right? And so the separation is what got us here in the first place, is what got us into the debacle in the first place. So when clinicians are working in the practices, and again, I really want to say we hire people who know their stuff, right? Who are able to, and so we haven't really had much pushback at all, because I will say, there are other PCBH programs which are having clinicians see 15 patients a day. We do not do that. We do not do that. You have 6.5 is your productivity for seeing patients face to face. And then if you try your best to meet that quota. If you can't, then you have your CoCM work, which is important and very valuable work to be able to do with that patient, with the patient population. And we don't have a requirement for that. I will tell you, by the way, we don't set a requirement. It's whoever has the need for what we consider specialty care by looping in psychiatry. This, by the way, just so you know, this model, even with the CoCM and PCBH together, is also not a new model. It used to be called something differently many years ago. But really Intermountain, and again, going back to the VA, it used to be called the behavioral health clinician and the behavioral health clinician assistant. And back then you couldn't get paid at all for the assistant. There was no pay. for the assistant, you know? It wasn't until G codes went active 4 or 5 years ago, and then when CoCM codes were widely adopted 3 years ago. I might have my timing off, but it feels like, you know, so this isn't new. It's just new that we're finally able to get paid for it. And that's what we have to make sure that we're, you know, and in order to get paid, right, you have to make sure that you're crossing your T's and you're dotting your I's and you follow JCO requirements. So, you know, we have a lot of mandates by nature of working for a healthcare system that we have to do things in a certain way. Does that answer your question, Kim?
Absolutely. So helpful. Thank you.
Oh, absolutely. Thank you.
And I just have to say, you guys are doing such amazing work. And thank you for sharing these examples. It helps me in different parts of the country think about this a little differently.
I agree with Kim. You know, this is about different ways of leveraging different shared care elements. And there's going to be pros and cons depending upon, you know, how we put these together. The models like CoCM help to give us a way of organizing these shared care elements that are evidence-based, showing to improve on the quadruple aim. But there's a lot of different ways different organizations can conceptualize and use these pros and cons, you know, with each. So this has just been an outstanding conversation of just seeing different ways we can leverage and conceptualize BHCM hiring ratios, and it's expanded to many other things that I think are valuable insights. Thank you all for coming today, and what we'll do is see you after the new year. Keep communicating on the Basecamp in the meantime.
Don't forget, these are all recorded and end up on the YouTube channel and the CFHA website. So thank you. Have a great new
Thanks,
year.
everyone.